Thank you, Dr. Shuren. We'll now have a round of 5 minutes questioning Dr. DeSalvo. In 1980, when I was governor of Tennessee, I had the big idea that all 8th graders would become computer literate. So I flew to San Francisco, met with Steve Jobs, and bought enough Mac computers, they were big, tall things then, to put in all the middle schools. It was a great idea. It sounded good. Forgot something. I forgot teacher training. So nobody really knew how to do it. I didn't think it all the way through to the end. I think we have something of the same problem with our electronic healthcare record system. We spent $28 billion. It's a great idea. It holds great promise, but it's not working the way it's supposed to. The current standards for meaningful use aren't clear. Upgrades are expensive. The systems don't work well enough to share the data. We hear it's expensive to share the data because of the relationships between vendors and doctors. Some of the doctors call this data blocking. You just released a report on data blocking describing these concerns. Senator Murray and I have set up a group, a working group to work on this because of the large amount of interest in our committee on the subject. My question is, will you work with us, this committee, to identify the 5 or 6 steps we could take to get our electronic medical records system functioning well enough so that it supports not just the precision medicine effort that we have, but so that it functions and it's something that physicians and providers can look forward to using instead of enduring?
Yes, Senator, I very much look forward to working with you all on identifying ways that we can make this work for doctors and others on the ground, on the front lines, because that's where it really matters, where the workflows are sometimes not the way they ought to be. They can be clunky. And so we look forward to that, and you can count on our participation very actively. We have some efforts underway. As the Senator is likely aware, we've been working through our rules for meaningful use, for certification, the blocking report, and other strategies, but we know there's more work to be done, and we look forward to that.
Well, good. And what I'm talking about here is actually beginning to get some results. I mean, identifying the 5 or 6 steps we should take. You should know them better than we, really. Although Dr. Cassidy has some personal experience in this, he'll give us, I'm sure. And then going step by step to get them done. And if you can do them by administrative order, terrific. If we need to do something, we'll include them as part of our innovation initiative and begin to do what we ought to do. Dr. Collins, 1 million genomes. I mentioned I was visited by the head of Philadelphia's Children's Hospital. They have 250,000 sequenced genomes. And so I have two questions. Well, one question. How many of these are already out there? I mean, you want to assemble 1 million. They've got 250,000 in Philadelphia. Dr. Vintner wants to assemble 1 million. Can you get your 1 million genomes simply by going to places like the Philadelphia Children's Hospital and using some of theirs?
That's a great question, Senator. And we are, in fact, trying to come up with every possible way to assemble this million-strong cohort by taking advantage of things that have already been done instead of having to start from scratch. And we will, in fact, have a major meeting in your state on May 27, 28, with a number of those who have been managing these large-scale cohorts gathering together to see if there is a way to put them together in a way that would prevent us.
Can you estimate the number of genomes that have been sequenced in this?
So I should be clear, when you say genome sequencing, some people are referring to a sampling of some of the base pairs in the genome, a genotype, a SNP chip is the term that's often used. Some are talking about sequencing just the parts of the genome that code for protein, and we call that the exome, E-X-O-M-E. To do a whole genome sequence is substantially more expensive, but is becoming now quite affordable. Most of the cohorts that are out there have not yet done whole genome sequencing. The group in Philadelphia is doing that with some of their patients, but not with many of them. Dr. Venter certainly has the intention in his Human Longevity Institute of doing a lot of whole genome sequencing. We believe that to get the maximum information, you want that.
Let me ask you quickly, Senator Murray has emphasized the importance of making sure everyone or a representative group of everyone's included in this. What about children? I mean, the suggestion was made this morning that sequencing the genome of a child for a genetic defect leading to a particular disease can be less complicated than for an older person who may have a more complex disease. Will you include children in the single gene therapy treatment as part of what you do?
That is an active area of investigation by our working group. Let me explain that we have assembled a group of both public and private experts on this whole question of this million-strong cohort. They have met once last week. They will be meeting again specifically to talk about what should be the constitution of this cohort. Should children be included? What should we do about individuals that may not otherwise be asked to participate? We want to be sure this covers diversity of our population as well. And some of the cohorts that are already out there may not be as diverse as what we need. We will figure this out. I think there is a desire, however, Senator, to have this be something that represents the broad swath of our country. And so there will be a strong motivation for many people to include children.
Thank you, Senator Murray.